Stop the bleed post-vaccine, a case of refractory immune thrombocytopenic purpura induced by the COVID-19 vaccine. Immune thrombocytopenic purpura is an autoimmune disorder caused by autoantibodies against platelet antigens, resulting in platelet destruction and impaired platelet production. It is the second most common acquired thrombocytopenia following chemotherapy-induced thrombocytopenia and has an annual incidence of 1 to 6 per 100,000. In some patients, an inciting event such as a virus or vaccine can precipitate ITP. The COVID-19 virus and vaccine in particular may induce immune-mediated platelet disorders. Because ITP is a diagnosis of exclusion, treatment response is the only way to confirm the diagnosis. Most patients can be treated with first-line therapy, but some patients develop refractory ITP that does not respond to initial treatment and can be very difficult to manage. Here, we present a case of a 24-year-old male with a past medical history significant only for obesity that presented after a cat scratch to the right arm with persistent bleeding from the scratch site. He also reported gum bleeding over the past 1 week. The patient received the mRNA-based Pfizer COVID-19 vaccine 2 weeks prior to presentation, but otherwise denied any significant recent exposures. He has a family history of ITP in his mother. Vital signs were normal, and physical exam revealed a generalized petechial rash. Initial labs were notable for severe thrombocytopenia with a platelet count of 1,000. He then developed severe gastrointestinal bleeding and encephalopathy, requiring intubation, massive transfusion protocol, and transfer to the intensive care unit. A peripheral blood smear was done, as you can see in Figure 1, and showed severe thrombocytopenia with almost no visible platelets, but no evidence of schistocytes or blasts. The patient was suspected to have ITP and was treated with both high-dose steroids and then IVIG without improvement in platelet count. A bone marrow biopsy was then done and showed a hypocellular bone marrow with 20 to 40% cells and increased megakaryocytes, as you can see in Figure 2. The patient was then started on weekly rituximab, which is a monoclonal antibody, and eltrombopag, also known as Promacta, which is a bone marrow stimulant. However, platelet counts did not increase above 7,000 with these therapies. He was then given romiplostim, also known as Nplate, which is another bone marrow stimulant, and treated with plasmapheresis for refractory ITP. However, platelet counts still did not improve. Eventually, there was concern that the patient may have a different diagnosis of hemophagocytic lymphohistiocytosis, and he was started on immunosuppressive therapy with cyclosporin. Despite this and the multiple other therapies, the thrombocytopenia was refractory, and the patient ultimately had to undergo a splenectomy. Figure 3 is a pathology slide of the spleen. You can see that the spleen is diffusely depleted of white pulp with absent lymphoid follicles, germinal centers, and perifollicular zones. The periarteriolar lymphoid sheath, as indicated by the arrow, has diminished lymphocytes. After the splenectomy, the patient's platelet counts finally recovered to about 300,000, and he was able to be discharged on a steroid taper with a diagnosis of refractory ITP, likely secondary to the COVID-19 vaccine. Because mRNA-based COVID-19 vaccines have only been available for a short period of time, there is not much literature regarding vaccine-induced adverse events, including immune thrombocytopenic disorders. Given the widespread use of these vaccines around the world, it is very important to document vaccine events, especially in vulnerable patient populations. In particular, our patient's family history of ITP in his mother may have increased his risk of developing vaccine-induced ITP. As ITP is a diagnosis of exclusion, patients often receive multiple therapies before a diagnosis can be officially made. Treatment of ITP is typically warranted when platelet counts are less than 50,000 with signs of bleeding, or if platelet counts are less than 20 to 30,000. First-line therapy is with high-dose steroids, which is preferred, or IVIG. Patients that fail to respond to first-line therapy may require treatment with bone marrow stimulating agents, immunosuppressive therapies, and even splenectomy in order to diagnose and treat ITP. Because treatment can be so aggressive, it is very important to quickly and accurately diagnose ITP. Despite the adverse effects potentially associated with vaccines, it is important to note that vaccine events are rare and do not diminish the overwhelming utility of vaccination.